professor in allergy and infection. We're getting feedback here. Hello. Hello. I see the chat saying it works on your end, but we're getting feedback on that. You whizzes.
If we can get Sarah's laptop volume down, we'll be good to go.
Hello?
Okay.
Perfect. Okay. All right, I'll start again. So my pleasure to introduce Sarah Nelson-Glick. Sarah is a practicing epidemiologist with Public Health Seattle-King County, America's 14th largest county, I believe. She's also an associate professor in allergy and infectious diseases and adjunct in epi. I've known Sarah since she was a PhD student here, finishing up early on in my tenure, and I was very excited when she was doing her dissertation on sort of life course perspectives on sexual behavior and sexual risk among men who have sex with men in the US and its relationship to HIV, and really thinking about how that unfolds over one's 20s, 30s, 40s, et cetera, in a way that I hadn't seen much work on before. So starting off with her CSDE demographic kudos. Since then, she's worked on lots of different themes within the epidemiology of HIV in the US in terms of sexual behavior, racial disparities in service delivery, extended that work into other sexually transmitted infections, into other countries like Kenya, and into other methodologies, really looking at creative ideas about, sort of sexual health diaries and use of smartphones really early on when that was a new thing, and into new populations, and work with trans health, and now, as you'll hear today, a lot with folks who inject drugs. Dr. Glick is the Seattle head for this nationwide CDC sort of consortium called the National HIV Behavioral Surveillance System, which is a system in 23 major metropolitan areas across the US that has been going for a long time, documenting all of the sort of behaviors and care access and everything for populations at risk for HIV. It rotates every 3 years. 1 year is men who have sex with men and now trans women. One is folks who inject drugs, and one is heterosexuals at higher risk for HIV. And so Sarah leads it all for Seattle. And then more recently has been the PI on the CDC project, doing national evaluations for syringe service programs, and I believe that is part of what we're going to hear about today, right? So, I will end with what I think is the most salient fact about Dr. Glick, which is that her bachelor's degree is in biological anthropology. So, we like to see ourselves represented. So
it was meant to be.
It was meant to be. On that note.
Oh, thanks, Steve. Thanks, everyone. Let me see if I can now share this. Really surreal being on this side of the podium for a CSDE seminar, because you spend so many years as a student on that side of the podium, and so it's pretty neat to be up here. But thank you so much, Steve. You made me want to go back and do some of my old research again. I haven't thought about some of those topics for a long, long time, but I did make a pretty substantial switch in my my research. When I moved back to Seattle about 8 years ago, there had been a retirement at the health department. She had worked as an epidemiologist there for many years and focused on injection drug use and substance use. And when she retired, there really weren't that many people focused on it. And so I made a pretty concerted effort at that point to switch gears, which ended up working out really well in many ways and has really opened the doors to a lot of really interesting projects, one of which I'm going to be talking about today. I do need to make one small change to the title. We, as I'll talk with you about, we did involve 9 programs. Okay, there it is. But I'm only presenting data on 6 programs today because we are still wrapping up analysis for the last 3. Actually, we're wrapping up data collection for the last 1. And so I'm actually on the docket for a CSSS talk in May. And so I am planning to present more of the data there. So as Steve mentioned, I'm both at the UW and at the health department. This work is interesting because it's technically through the University of Washington, but it's funded by the CDC. So it's kind of an interesting marriage. CDC typically funds health departments, not academic institutions. And so I'm going to talk about this big old project that we've been doing over the past 3 years. And like I said, it was funded by CDC, and it was really from the HIV group originally at the CDC as a way to focus on people who use drugs, people who inject drugs. And you may not have thought about HIV and people who inject drugs, maybe at all if you're not in public health. But for a while, for a very long time, we had been seeing a really positive decline in the number of new HIV cases among people who inject drugs. I mean, this had been going on since the 90s when we had our first powerful medications, and the number of new cases continued to drop. And then in the mid-2010s, there was this real stalling out, looking at the number of new infections each year. And this, of course, coincided directly with the opioid crisis, where we have a lot more people using drugs, we have a lot of risky drug use. And so the number of new HIV cases per year has either stalled or maybe even increased a little bit. But I think it's really important to highlight that it is not just HIV that we're focused on when we're thinking about people who use drugs and people who inject drugs. Frankly, HIV risk is relatively low compared to a lot of these other outcomes, especially when we're thinking about opioid overdose. We're currently at a historic high with the number of fatal overdoses here in the United States per year. For those of you who don't know, here in Washington, we're the state that's had the highest increase in the number of new overdose deaths in the past year. Our rates are still not as high as some states, but our trend is trending up the fastest. And so we're at a really bad place right now here in Washington. And that is largely due to the influx of fentanyl in our drug supply, which hadn't reached us for a long time. It had reached the East Coast, caused a lot of their overdose crises, and now it is on the West Coast, including here in Seattle. So there have been sharp increases across the country with fatal overdoses, but really any health outcome that impacts people who use drugs has been impacted, including all of these listed here. And so when thinking about prevention among this population, one of the primary prevention strategies, it's really a framework or philosophy, is through something called harm reduction. And so this is a way of thinking about how to reduce the risk of adverse outcomes among people who use drugs, but not necessarily ask them to abstain from drugs entirely. So that is where the harm reduction framework comes into play. We're thinking about how to reduce risk. We're meeting someone where they're at, what they need now to reduce their risk for HIV, but not necessarily prioritizing abstinence. So for example, providing sterile syringes is a key harm reduction activity for people who inject drugs, because what we're trying to do is reduce the risks that come from injection, but not necessarily eliminate the drug use. But the idea is that when somebody is ready for treatment or ready to abstain from drugs, they're linked into programs in a trusted group of people who can help them get those resources. So syringe services programs or needle exchange programs have been around since pretty much the start of the HIV epidemic, since the 80s. A fun fact is that the public health syringe services program here in Key County was the second above board needle exchange program in the country. The first was in Tacoma. So the Pacific Northwest has a really nice history of supporting harm reduction. The CDC has not. So for many, many years, the CDC and the federal government has been very negative toward harm reduction. You know, you couldn't say the words needle exchange or syringe exchange. It has not been funded. So there was a long history of that, and there are still a lot of policies that do need to change. There is a group at CDC now and a group at SAMHSA and throughout, you know, pockets of the federal government that is embracing harm reduction, is working toward increasing funding and, you know, rolling it out in a bigger way. And so we have been fortunate to work with one of those groups at CDC that has been trying to expand its harm reduction work. And they have been doing that through funding several programs, including the project I'm going to talk about today, which is Project NEXUS. But we've also done some national survey work of programs themselves. And we've been providing technical assistance through a National Harm Reduction Technical Assistance Center. So I'm going to be talking about one of the surveillance projects, which is called Project NEXUS. So this is just a really, really high, simple overview of Project NEXUS. This is a survey among people who use drugs, which I'm going to abbreviate as PWUD. And the goals are to assess their drug and sexual behaviors, assess their access and use of prevention services like HIV testing or PrEP or syringe exchange, and then also monitor the prevalence of HIV and hepatitis C infection. The findings are aimed to be used at many levels. So by the CDC, by us, and also by the syringe services programs that we partner with, in order to inform prevention activities. Sorry, the screen just went black. And so what is new about Project NEXUS relative to other surveys has been this focus on what the CDC and we say are underrepresented people who use drugs. And so who are those people? As I'll be sharing with you, Steve already mentioned it in my intro, there are other surveys that focus on people who inject drugs, and these are in urban areas. And so there are many, many pockets of the country where there is not regular surveillance or data collection about people who use drugs. And so that includes rural and suburban areas, as well as smaller urban areas. And it includes people who use drugs in other ways than injection. So there are many ways to use drugs, including smoking or vaporizing, ingestion. And so that's actually what's becoming more and more prevalent in places like the West Coast, like here in Seattle. And so a lot of the surveys that are being conducted for people who use drugs focus on people who inject drugs. And so there is a real gap and need for more data on people who use drugs in other ways. So those are the two main criteria that I'll be talking a little bit more about. And then another big piece of this is that a lot of the funding tends to go to health departments or to research institutions. And so the money stays in these organizations that already have a lot of money and a lot of staff capacity. And then we, tap into working at a needle exchange for 6 months, and then we leave. So the idea, as I'll share with Project NEXUS, was really to involve the syringe exchange programs from the start, to embed staff there, basically train their staff to do the project, to build their capacity to do surveys and to do more research-like activities, and then to leave them with both that capacity as well as the data. And so if I have time, I can share basically what benefits each of the sites we worked with had. So these were our goals with trying to focus on more underrepresented people who use drugs. So I know this is a methods group, and so the way I'm going to give the rest of this talk is I'm going to focus more on methods. I'll give you some results, some of the key findings, but I really wanted to use this as an opportunity to share some of our experiences with the methods. I'm really hoping to get questions and feedback and thoughts from you all, because we're still very much in a stage of the project where we are trying to sift through things ourselves and make final recommendations to the CDC about how these data can be used. Okay, so Project NEXUS was a demonstration project. That is literally what it was called in the grant proposal. And so it was designed to be, you know, this thought exercise of, can we do this and what can we learn from it? And so there were a lot of questions that we had. I'm going to focus today on our methodologic questions and specifically around sampling. And so those are things like, could we recruit a representative sample of search services programs to participate as recruitment sites? Can we systematically or even randomly recruit participants? Would referral cards help recruit people who don't get services at search services programs or people who don't inject drugs? And then ultimately, to what population can we generalize our findings? So that's what I'm going to focus on today. We also had a lot of implementation questions. So like, could these programs actually staff and train staff and have space to do this survey? Can they build this survey into their typical flow of providing services? Would the project have any lasting impact on the project once we left? And then this last one could not be more boring, but honestly, it's what I spend, I think, that half of my time working on, which is the contracting process. This is actually a really important component of doing research. And so when we're working with programs that are often grassroots, they don't have large fiscal staff, how can they contract on a federal grant is actually really complicated. And so I will not go into that today, but it was a big part of this project. Okay, so Steve already alluded to the fact there is a national system that's also funded by the CDC called the National HIV Behavioral Surveillance System, or NHBS. And this is that 20 site or 23 site survey where we rotate between populations at high risk for HIV every year. For example, this year we're focused on men who have sex with men, and next year we'll focus on people who inject drugs. And so here were the cities that were funded at the time that NEXUS started. So it's map's a little bit different now, but this is where we were when NEXUS started. So you can see there's a lot of geographic gaps, both within states and between states. And these are all large metropolitan areas by design. Those are the only areas that are eligible to apply for NHBS. And so I feel like this is the group where I'm the safest talking about respondent-driven sampling, because I usually have to provide a lot of background here, but I'm assuming I don't. NHBS does use RDS to recruit participants. So for those of you who don't know, we identify a handful of seeds. So these are people that we know should meet the eligibility criteria and are well networked. We bring them in to complete the survey. And then if they are eligible, they complete the survey, they receive coupons. They can take those coupons out to their peers and then invite their peers to come in and complete the survey. And so it snowballs out from there. It's incentivized. So if one of your peers participates, you get an incentive for recruiting them. And so this has worked really well with people who inject drugs here in Seattle. We I think we always meet our sample size goals. And so it's worked really well. But there are some limitations. So as I already alluded to, the way that people use drugs has changed a lot. So we of course still have people who inject drugs, but we also have a lot of people who don't inject drugs. And so using RDS, that has focused on injection drug use. And so we really want to try to include people who don't inject drugs. So that's one limitation of using the NHBS data in this recruitment strategy. And then, as I also mentioned, these RDS surveys tend to be conducted by health departments rather than the programs themselves. And so we were really trying to, if possible, embed support and resources and capacity building at the programs themselves rather than keeping that in the health department. So we sought out to identify programs to participate as our sites. And it was so funny when I got the first RFP to respond to apply for this grant. It said, you'll be conducting this in 30 sites. And I responded, and I was thinking, okay, we do 30 sites, it's just gonna be these mini surveys, no testing, it's gonna be these short little surveys. And then when it got funded, they're like, oh no, we're gonna actually do something like NHBS, which is a huge undertaking. And we were like, there aren't even 30 NHBS cities. How can, this grant be used to fund 30 NHBS like surveys at needle exchange programs? And they're like, oh, actually you only have to do 4 to 6. Wow, that is a huge difference. So it just shows you, you see in these call for proposals can be very different than what you do in real life. So they're like 4 to 6. So like, okay, we'll try 6. And so what we initially were asked to do is to try to find a random sample of syringe services programs. So there is an SSP directory online. It's maintained by NEXUS, which is the Tacoma Needle Exchange, so the first needle exchange. They have an online directory and it is considered the most comprehensive list of needle exchange programs. So we were supposed to take that list and then randomly sample programs to these sites. And they also, the CDC asked us to take into account the size of the program, how many years it had been open, what kind of services it provided, and its geography. So we were going to do some sort of, stratified random sampling. And so we tried that. We got the list from Mason, they were a partner of ours. And we developed this table where we had our criteria. So the CDC asked us to focus on states that had the highest number of opioid overdose deaths. So that immediately took out 25 states of programs. And then we also were not supposed to focus on needle exchange programs that were in NHBS jurisdictions, because again, we want to try to find programs in other areas. So programs from those 25 or 23 MSAs were excluded. And then because we wanted 6 sites, we were like, how can we divide the country up into 6 regions? So we found that there are 6 Census Bureau offices. It's a little random, but we picked those 6 geographic areas and we created these tables where we had our 6 areas and then we randomly chose the syringe distribution model. I won't get into that, but there are different models of providing syringes. And so this is just one screenshot of the programs that met the criteria for the LA region, and our model was just another model. And so we put all of the programs that met those criteria into this spreadsheet, we gave them random numbers, and then we ordered them. And we just were supposed to start on the top of the list and just start going down and cold calling these programs. Now, this was in like July of 2020, which could not have been a worse time to try to reach out to a struggling program to ask them if they can survey 300 people. And so we tried, we started calling each of these programs and it was taking absolutely forever. Very coincidentally, this very first program did say yes. So we thought, when they first said yes, we thought, oh, this isn't so bad. But I bet we went through 40 more after this and we kept getting no's. We can't do it, we don't have staffing, we just don't have capacity to do this right now. So we kept on, and we ended up getting 4 programs to say yes using this method. And then we were desperate, so we put out a call for proposals to ask people to apply to us. And so then we were able to go through their application and quickly select 2 more. So that's how we ended up getting our 6 sites. It was a combination of this attempt at random selection and then a call for proposals. And I will say the call for proposals was really a really great experience because we could be we knew we needed somebody in this part of the country, and so then we could find one in that part of the country, or we needed somebody who was more of a grassroots program, so we were able to do that. But of course, it wasn't a random selection by any means. So that is how we ended up with our 6 sites, and here they are. So we had one in Ellensburg, that was the one I mentioned. We had one in Missoula, Montana. We had one in Sacramento, California. We had one in Madison, Wisconsin, one in New Haven, Connecticut, and then one in Wilmington, North Carolina. And yes, our focus, I don't know why I added that there, but these were our first 6 sites. So we were really excited to be working with them. And so once we got the 6 sites on board, we got the contract set up, how did people actually participate in this survey? Well, this was another thing where CDC had something on paper, and then when we really had to make it work in the real world, there were a lot of challenges. So they wanted us to do some sort of systematic recruitment of participants. And that could look like something like every third third client who comes in the door could be approached to be in this survey, or every other, or every 10th, depending on how busy the place is. But the reality is, if you spend any time in a needle exchange program, it doesn't flow that way. People often come in groups, and so it can be hard to split people by group. People tend to, be quite poor. And so anytime you are providing a monetary incentive for a project, there is a lot of enthusiasm for it. And so when you're saying, can you participate in the survey, but you can't, it creates really difficult dynamics. And especially because the program wants to maintain a great relationship with everybody. And so it ends up looking like we're choosing you and not you to do this project to earn money. And so we told them at the very beginning, we can't do every third person or every fifth person. It's just not gonna work. It looks good on paper, but it's just not gonna work in reality. And so the compromise that we made is that programs would try to recruit everybody. And so everybody would be approached to participate in the survey. If they had time and space, then they would do it. If they didn't, they could either come back another time. We could try to do appointments, but everybody who came in was invited to participate. So that was our way of still doing it systematically, but not in a every third type way. So that was the main reason, the main strategy for recruiting people was direct recruitment from staff. But then we had other methods. It was not an RDS survey, so we did not use true respondent-driven sampling, but we did use incentivized peer referral. So participants who did participate were given referral cards. They could give those to their peers. They could get a $10 incentive, but we didn't track the connections and the networks. And certainly there were other ways to participate in the survey rather than just the coupon, which is what you have in RDS. And then also word of mouth. Honestly, we were interested in seeing who could come in and who might be interested. So if they heard about the survey from somebody else, they'd never been to the program, they could still come in and then ask to participate. So we use a lot of different strategies, and as I'll show you, people participated in a lot of different ways. So then once somebody was in the program site to participate, we did a virtual health survey. Again, this was in the middle of that first year of COVID. And so we wanted to try to minimize the face-to-face talking time. And so the program would set somebody up in front of a computer in a little station, and they would do a survey with an interviewer that was based in Seattle. And believe it or not, it worked really well. We did, as I'll show you, over 1,500 surveys this way. So we had this little army of interviewers based here in Seattle, and they would just interview people, across the country all day. And NHBS ended up adapting that method for their whole PWID cycle because it was successful with NEXUS. So it was pretty cool that it worked out. We didn't know what to expect, but it did work out. And so people who were completed the survey got a $40 incentive. Took about 30 minutes or so, and there were both core questions that we asked, and then each site was allowed 10 questions that was specific to them, and they could tailor to what they wanted to learn about. To be eligible, just a quick sideline here, people needed to be 18 years or older. As I already mentioned, they needed to either report injecting drugs or use injecting drugs through non-injecting routes in the past 6 months. So what that meant was people who only used marijuana were not eligible, but people who smoked crack were eligible. People needed to be able to complete the survey in English. This was a pretty big sticking point with us. We really wanted to be able to offer it in other languages, but the translation takes a long time, apparently, at the CDC, and so they unfortunately weren't able to get that done for us. So that actually became a barrier at some of our sites. Of course, participants had to provide, it's called informed permission, since this is a surveillance project, it wasn't research, but it's basically like informed consent, and then they can only participate once. We also did HIV and hepatitis C testing. I'm not going to spend too much time on this today, but we did rapid HIV and rapid hepatitis C testing. And then we also collected what are called dry blood spots, which are like a piece of paper with 5 circles, and you can drop blood onto it. And then those papers can be tested for various things. And so we would send that to a lab, and they would then test for hepatitis C virus in the blood, which is a confirmatory test if somebody has active hepatitis C. So we did that. And then we would provide, or the staff would provide results back to the participant about their HIV and hepatitis C status. and they were linked to care if they needed it. So that is the general overview of the survey methods. I know we're gonna have time for questions at the end, so I'm not gonna pause here, so hold any questions at the end, because I'm sure there are a lot. But for ethical review, as I already alluded to, this was not a research project, even though it looked just like research, but because the CDC determined it to be a core surveillance project for them, that actually passes down to us. And so the UW-IRB made the same determination. All that really means is that we didn't have to go through like IRB review for changes to the protocol. If the CDC made a change to the protocol, we could implement it. So that's one of the ways that research differs from public health surveillance work. Even though it looked a lot like research. It was completely anonymous. We didn't collect any identifiers, so the data set was truly anonymous. Okay, so I'm going to present just a few findings and then some kind of closing thoughts and questions. So as I already mentioned, I think, we had over 1,500 complete and valid surveys. You can see we did really well at all of our sites. Our smallest site was in Ellensburg, Washington. This site had a goal of 150, so it was the only site that had a goal that wasn't 300. They did not reach it. It is a very, very small and rural site. They were only open a couple hours a day before we worked with them. They were able to expand the number of hours they were open, but they just don't have a lot of folks there. So 85 was really good for them. But you can see in all the other sites, we did a great job. Madison was our other site that didn't reach 300. The other sites reached 300. It was just we had to throw out a few interviews because they weren't valid. And yeah, we were really, really impressed. I don't think anybody thought we were going to get this many participants. So we did a great job. Or I should say the sites did a great job. And so I wanted to just share with you a little bit about the different sites, so you can kind of think about, did our recruitment strategy work? So we, this was from our report that'll be released pretty soon by the CDC. So we have different program size is usually determined by the number of syringes that are distributed per year. And so you can see we had quite a bit of variation. I would actually call Ellensburg very small, but it technically met the median criteria, but it's pretty small. So we had a pretty good distribution of different sizes. For urbanicity, I think we did pretty well. We had a couple of sites that were more in suburban areas, a couple in urban areas, and then we had our Ellensburg site, which was our one true rural site. So we'd like to get more rural representation in the future. All of our programs were needs-based. I kind of alluded to this earlier, but needs-based is basically where programs are allowed to provide as many syringes to participants as they need. And that's in contrast to what's called a 1-for-1 exchange, where like you bring in 20 syringes and I can give you 20 syringes back. Needs-based is considered best practices by the CDC because it does minimize any risk of sharing syringes, because you're in theory giving people as many syringes as they need so they don't have to share or reuse syringes. Whereas a more true 1-for-1 exchange can limit that because there are other ways to distribute syringes safely. And so if somebody can't bring them all into the program, they're limited in the number that they can take out. So it's actually a really good thing that all the programs were needs-based because that's what we want them to do. But it would have been good if we had had more representation of other types of programs. All of them had been in program or in operation for more than 5 years. I think this is largely a function of the COVID effect because the brand new programs were really still just trying to get, trying to like keep their head above water when we were recruiting them. So I think a lot of the newer programs just weren't in a place to agree to participate in this project. So we did have all longer standing programs. We had really good diversity in the organizational structures. So 3 of these were more grassroots type organizations. The New Haven one was related to Yale, so that was university. We had 1 FQHC, and then and that's a federally qualified health center. So something like Neighbor Care, that would be an equivalent. I don't think they have a needle exchange, but that's the type of program that an FQHC is. And then the Ellensburg program was affiliated with their health department, so nice variation there. And then I really like these data because you can see there was a lot of difference in how people ended up being recruited. So 3 of our programs did have a plurality of participants recruited through peer referral with the referral card. We had two programs that had the plurality of their participants recruited directly from their staff, and then one was through word of mouth. So there's actually quite a lot of difference here in how participants ended up getting recruited into the study. And so that is something that we continue to talk about. And when thinking about implementing this, in the future, I think really tightening up the protocol and working directly with the programs to understand, exactly, are you really recruiting everyone that's coming in to the program? Are you only relying on referral cards, and really trying to tighten up the protocol, I think could really help this out. But yeah, lots of variation there. Okay, so a little bit about our sample. This is pretty common in surveys of people who use drugs, to have roughly 2/3 of the sample be men, about 1/3 women, and then we had a smaller percent who were trans, non-binary, or genderqueer. You can see the racial distribution here as well as ethnic distribution. And those don't sum to 100% because people could select more than one. But overall, just about half reported any identity that was Black, Indigenous, or another person of color. So we had a pretty good racial representation. And then, not surprisingly, we had a really high level of homelessness in the past 6 months. Just over 2/3 reported that. That's also pretty typical for this type of work. So did we recruit people who both injected drugs and used drugs in other ways? That is a resounding yes. So only 7% of our population reported only injecting drugs. 70% reported using drugs in both ways, and then 23% reported only using drugs in non-injection ways. So that purple group is the group that wouldn't have ever been picked up in NHBS. So we were really pleased to include them in the survey. Okay, I'm gonna walk you through this because there are a bazillion numbers here. So I just wanted to show you how different drug use patterns are across the country. So we asked people what drugs they used, both through injection and non-injection routes. And so we'll start here, the blue square. So the purple bars reflect the 2 most commonly reported injected drugs, and the yellow bars reflect the 2 most commonly reported non-injecting drugs. And so overall, heroin and meth were pretty equal for injecting, and then for non-injecting, meth is slightly more common than heroin. But you can just see the stark differences between the 2 coasts. So on the West Coast, meth is the most commonly reported injecting drug and non-injectable drug, followed by heroin. And that's consistent across all 3 sites. But then on the East Coast, we mostly see the reverse, where we see either heroin or fentanyl, which is an opioid, being the most commonly reported injected drug. And then the most commonly reported non-injected drug is typically crack cocaine or methamphetamine. I have a PhD student right now, Caitlin Zisley, who is working on other data we collected from this project, where we actually tested their blood samples for drugs. And so we can do some validation work to see if the reported drug matches what was in the blood. And so she'll be working on that over the next year or so. So hopefully she'll be able to present that soon. But it was really interesting data. The meth use really is that high. A little bit about HIV and hepatitis C. As far as HIV testing goes, the majority had ever tested for HIV. Only 29% had tested in the past year, which is quite low. Recommendations would be for annual testing in that population. So it's a pretty low number. But again, this was during the pandemic where a lot of testing access virtually disappeared. So that's not that surprising. The HIV prevalence was just over 3%. It ranged from 2.5% to 4.2% across our 6 sites. This is in contrast to the NHBS prevalence, which is about 6%. So that reflects what we tend to see in more urban areas, a higher HIV prevalence, and in less urban areas, a lower HIV prevalence. And then the hepatitis C prevalence was about 20% had current, or we call chronic hepatitis C. 1% had acute hepatitis C, which means they had been recently infected with hepatitis C. And then that ranged across the 6 sites from 9 to 37% having one of those types of hep C. We saw that overdoses were common. This, is not ultimately that surprising given what we know from the mortality data. But in the past 6 months, 31% of people who used opioids had reported an overdose. 9% of people who reported using meth had an overdose or a bad reaction to meth. The word overdose isn't always used with stimulants. And then 8% have had a bad reaction to cocaine among those who used it. So certainly much higher levels of opioid overdose than other types of overdose. And then, I think this is my last real data slide. As far as naloxone is a medication that can be used to reverse the effects of an opioid overdose. You can get it for free. So I encourage you to go online. You can access it through the Kelly Ross Pharmacy, they'll mail it to you. So the vast majority of our participants had heard of naloxone, which is fantastic. Just over half had acquired naloxone in the past 6 months. And then a third of people reported that they had used naloxone on someone in the past 6 months. So really high levels of use, but also a third of people reported that they had been in a situation where naloxone was needed, but it wasn't available. So still a lot of unmet need. Okay, so I want to just summarize our what did we demonstrate or learn from this project? So going back to those first questions, can we recruit a representative sample of SSPs to participate as recruitment sites? And the answer here is like, maybe. I think we learned that we definitely can't do it through the cold calling method. That just didn't work. It was too labor intensive. It just took way too much time. Programs were suspicious. Like, why are you calling me? Where did this come from? They were caught off guard. And so I think our main recommendation is to use the call for proposal process, but of course you can build in guardrails to be really deliberate about who you would select and what sorts of characteristics of programs you would want. The other thing we learned that is really critical here is there are so many programs that just could never do this project. They're just too small. They don't have the space or the staffing, or a lot of places do not want to participate in research. And so there are just a lot of programs who would just never participate in this project. And so going through that motion of trying to convince them to do it is not a good use of time. And so, especially if they're never going to be able to do it. So I think the call for proposal process can be a really good way. It's never going to be a random sample, but it could be a very proposal sample. So can we systematically recruit participants? We definitely figured that no, we can't do that every third or every nth participant. But I think the idea of trying to recruit every participant did work at a lot of our sites. It didn't work at all of our sites. We did have some sites who relied, I think, too heavily on the referral cards. But I think, again, with tightening up the protocol and doing some more observations, we could definitely do more of the, attempted census type of recruitment. So that is also our recommendation. Did the referral cards help recruit people who either didn't attend the program or weren't injecting drugs? And I think they did, because you saw we got a good number of people who didn't report injecting drugs. Programs told us we are seeing so many people we've never seen before. We have a lot of new people coming in. So we definitely saw that. So I haven't been able to really show that yet in the data, but certainly by anecdote, we have seen this happen. And then finally, this is the question that keeps me up at night. How do we actually generalize the findings? And in the protocol from CDC, what they wanted us to do is recruit a sample of people who inject drugs and their drug using peers. And I think we did that. But I think I would change that a little bit. People who use syringe services programs and their peers, I think, and their drug using peers, I think would be more adequate. But we're caught in this tricky spot because we don't have a sample of people who inject drugs. And we certainly know we don't have a representative sample of people who don't inject drugs because they're still somehow linked to a syringe services program. And so this is a really tricky one. And I think there is still so much value in including people who don't inject drugs in the sample that I would not want to go back to a protocol that just for people who just inject drugs. But I think we also just have to recognize we're not going to get a fully representative sample of people who don't inject drugs either. And I'm not sure how to do that. I don't think anyone knows how to do that because otherwise we'd have that data. So this is a tricky one. I'd love to hear your thoughts on this too. But this is the one that definitely, you know, like I said, keeps me up at night sometimes. And then I watch Schitt's Creek and it's all good. Okay, so I'm just gonna close out here. We did get funding to do this again. So those are the 3 more sites I'm gonna be presenting at CSSS in May. And we have a site in Anderson, Indiana, which is another rural site. We have New Orleans, and we have Newark, New Jersey. For this project, which was interesting, CDC specifically wanted us to focus on areas that were in NHBS jurisdictions because they wanted to be able to compare the data between the NEXUS protocol and the NHBS protocol. So New Orleans and Anderson, Indiana have reached their recruitment goals. And then Newark, New Jersey is almost there. They're aiming for 300. And we asked the participants, did you participate in your local NHBS last year? And you can see that, you know, only the minority did. We really thought, especially New Orleans and Newark, that this would be higher because we are literally doing this survey at the same site. Like it is the same physical location, frequently the same staff, only 1 year apart, and yet we're only getting 20% overlap, which I think surprised everybody. We thought this would be a lot bigger. But I think it means the referral cards are bringing in new people, and there's just so much churn in the population of people who inject drugs and use drugs. So I think that was really interesting. Anderson, Indiana, that's not surprising because the study site for NHBS is in Indianapolis, and Anderson, as I know because I've driven there, is an hour outside of Indianapolis. So it wasn't surprising. That one we knew would be small, but the other 2 were literally in the same site. So just kind of an interesting RDS versus other recruitment site finding. So I'm just going to conclude. I'm not going to go through all of the site experiences. I'm happy to talk about them if you're interested. But I'm just going to flash through the photos because I like looking at the photos of our different sites. And basically the bottom line here is that all of them had some pretty great improvements of their programs, whether that was an increase in hours, an increase in participants, an increase in the diversity of their participants. But we heard nothing but really positive feedback from our 6 sites. And so I do think we left them with something. And most of them said, you know, when can we do this again? So I think, you know, I always interpret that as a good sign as well. Finally, there have been about, I mean, literally 100 people who have worked on this project over the past few years. And Jeremy Beckford is here. So he has been our data manager over the past couple years. So thank you, Jeremy. And a special shout out to Morgan at the UW, who's been our coordinator for all of this. But yeah, that was our army of interviewers in the green box. And then each of our sites has a whole team. And then our next 2 sites are wrapping up. So that's it. I'm happy to answer any questions you have. Thank you for being such an attentive audience. Questions?
I have a question. But I don't know who else would. You're monitoring. Yeah. Sarah, that was great. Super interesting. Sounds like a massive administrative job to manage. And really appreciated learning about it. I was thinking about the dilemma of trying to get rural or just thinking about non-injecting drug users and their behaviors, their social context. I'm a sociologist, demographer. I wanted to know more about those particular people who ended up coming into your SSP sites. And just wondering if CDC allows you to do qualitative work to find out where, how do these people, where are they? And where do they live? That's one thing. And then the other, and what are their social networks and their friendship networks and their peer connections. And the other question I have for you is, or with regards to your last point about the lack of overlap between the two populations within 1 year. And thinking about that little thing you said about churn. So I'm wondering if there's anything in your data, or if you plan to collect new data around where were their life course, recent life course histories, where they've been, where they're living, especially if so many of them are experiencing homelessness. Could they be moving in other places? And yeah, so lots of questions that try to get at how do you get at this population that might help you with your sampling strategy.
Yeah, no, those are fantastic questions. I think if we had even 6 more months of a timeline, we would have asked sites to do more formative qualitative work before they even started to answer some of those network questions that you were asking. And that is what we do with NHPS. We have a formative period where we do go out, we do interviews with community members, as well as other key stakeholders who work with community members to better understand networks and where people could be recruited, what are strategies for recruiting them, what can make this project appealing to them. But we didn't have that with NEXUS. And so we were just going in, with the quantitative survey. Anecdotally, what we heard, especially from the Ellensburg site, was that there is just so, and this is everywhere, there's so much stigma around substance use, right? But especially in a rural area where people know each other, you're visible going into needle exchange programs. There's so much hesitancy to even go into a needle exchange program that, that's the first barrier. And then there's trying to recruit somebody to be in a survey. So this program we worked with was relatively new itself, and they were very forthcoming that they were still trying to establish trust with the community. And so I would have really liked to go to, a more established rural program as well and see, it is a program that already has that trust in the community. Are they more able to recruit people, to participate because they have more people coming in the door? We also heard that networks are pretty small in those rural areas. So people might know their partner who also uses drugs, but they're not necessarily linked to other people. It's more of a dyad. Whereas like in an urban area like Seattle, there's just, the networks are just so much more far reaching. So that's what we learned anecdotally through NEXUS. And then you'll have to just remind me of your second question, because I knew what it was.
Just life course.
Life course, yeah.
About your respondents.
Yeah, unfortunately, again, we weren't able to ask those questions. I think certainly seeing the data we know now, we would have asked them, where did you live a year ago? Is there a reason? Is that the reason why you weren't picked up by NHPS? Or, are there other reasons? Is it more of a recruitment issue, or was it more of a mobility, migration issue where people are living? So again, what we mostly know is anecdotally, but what we can do, and this is a good reminder, we do a follow-up focus group with the staff at each site after we wrap up each survey. And so we could ask them at least for their insight on like how their clientele have changed over, a year or two, and how much churn they typically see. Thanks for those questions. Yeah.
I apologize, I partially attended your talk, so you might have covered this already, but I have 2 questions. So first is, I wonder what traditional needle exchange programs could offer given the changing dynamic of route of the administration of the drugs. So what would harm reduction would look like? And second is, how much is HIV is co-occurring for individuals who use drugs in Washington State or nationally overall?
Yeah, 2 good questions. So the first question was about what harm reduction strategies or services can be provided to people who don't inject drugs. So one of the primary strategies is safer smoking equipment. And so that can be in the form of glass pipes. So there are multiple kinds of pipes. Some pipes are more commonly used for methamphetamine or crack or heroin. And so you can provide pipes to people that, you know, are of course sterile, and there are different trains of thought around like what is the ultimate benefit of providing pipes, because there's not too much of a risk of bloodborne infection, but smoking drugs compared to injecting drugs reduces the risk of overdose. So that's important. And of course, smoking drugs compared to injecting reduces the risk of bloodborne infection. So that is one of the main strategies. You can also provide foil, which a lot of people smoke off of foil. So you can provide something as simple as foil to people. So I don't remember the exact count. I think almost all of our programs provide safe smoking supplies. Certainly the one in Missoula, Montana, they saw so many people coming in who were smoking, it increased their program. So they were really happy about that. So that is one of the main strategies that, you know, the programs use. To answer your other question about HIV among people who inject drugs, here in Seattle, we estimate that the prevalence of HIV among people who inject drugs is probably somewhere between 3 and 5%. So 3 and 5% of people who inject drugs have HIV. That's lower than other metropolitan areas. You know, with NHBS, the average is 6% across all of the 20 sites. And just to give you some context, in the population that has among the highest risk for HIV, which is men who have sex with men, we see a prevalence in Seattle of around 11%, and nationally it's a little bit higher. So, you know, it is a lower proportion than some of the other populations, but it is a higher proportion than, say, you know, population who engages in heterosexual sex. So it's kind of in between those. Yeah.
Because other diseases probably alcohol is more common.
Yeah, I see. So yeah, other comorbidities. Absolutely, you know, especially things like mental health disorders, very, very high prevalence among people who use drugs or inject drugs. And then other types of substance use disorders like alcoholism, in particular alcohol use disorder, are also going to be higher. We didn't actually measure alcohol use disorder in NEXUS, so we don't have a validated measure of that in the survey. Any other questions? Were there any online? I didn't see any. Okay. Well, if you think of anything over today or the weekend, if you have any thoughts, you can always send me an email or get in touch. I'm happy to talk about this project. The other thing I will say is, if either you or any student you mentor is interested in any of this data, it is available to be analyzed, certainly by students or faculty. We have, it's kind of working out for us. The CDC won't let us share the data with anybody else, so we can only use it within the UW. So we are definitely trying to use it as much as possible. So just let me know if that's of interest to you or anyone you know. Okay, thank you.